Good afternoon, and welcome everyone to our webinar on diabetes and your healthcare. Our returning presenter today is Dr. Cheryl A. Reynolds. Dr. Reynolds is a graduate of the University of Florida and Nova Southeastern University College of Optometry. She is an associate professor of optometry at Nova Southeastern University College of Optometry and director of the Retina Clinic. Also, she is a fellow in both the American Academy of Optometry and the Optometric Retina Society. Dr. Reynolds served as president of the National Optometric Association, NOA, from 2017 to 2021. She was awarded the NOA's Optometrist of the Year in 2013. She is a recipient of 2021 Women in Optometry Leadership Award and the American Optometric Association 2021 President's Award. Dr. Reynolds is the NOA's liaison to the National Eye Institute National Eye Health Education Program. And Dr. Reynolds, once again, we thank you for returning to educate us. The floor is yours.
Thank you so much for having me. It's really a pleasure to be here. I'm going to go ahead and share my screen. All right, so we're here today because I want to talk about a very important disease, a disease that is really dear to my heart. And many of you know someone, love someone that have had diabetes or has diabetes. So today we're going to talk about, during National Diabetes Awareness Month, diabetes and your eye health, what you need to know. Again, I'm an associate professor at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida. I was very honored to be president of an organization that's dedicated to advancing the visual health of minority populations. And I'm really proud to be part of the National Eye Health Education Program, which is part of the NEI. I'm part of the planning group, and I'm also co-chair of a program that will be geared towards African American increasing awareness of eye disease, eye health, my health. And just really quickly, again, the National Optometric Association, NOA, is an organization that has been, around for over 50 years, making sure that, there's awareness and education resources for our patients. And so our mission is advancing the visual health of minority populations. And the National Eye Health Education Program, NEHAP, which is part of the National Eye Institute, was established by Congress in 1988 to promote eye health as a public health priority and to prevent vision loss through outreach and education. We have 6 areas of our program: diabetes-related eye disease, vision rehabilitation, vision and aging, glaucoma. We also have dedicated Spanish and other languages. And then again, that new program that I'm so happy to be a part of. And we also have a planning group and partnership with various organizations. And so November is Diabetes Awareness Month, and that's why we're here. And so I want to thank the National Association Caucus for Black Aging for allowing me to be here today to talk about this important disease. So I want to start off by having everyone sort of participate and put in the chat if you know someone. Well, first of all, do you, a family member, or someone you know have diabetes? Just if you could put in yes, no, just kind of gauge, just an informal poll to see where we are. I mean, myself, my aunt had diabetes. She passed away from this disease. I see a resounding yes. We all, like I said before, know someone, love someone who's had this disease or who potentially could develop this disease. It affects family members, friends, uncles, cousins, associate. In fact, when we look at this disease, it's increasing in prevalence. Diabetes, but a lot of times understanding the disease for the patients that I see, it's hard. They don't really understand their disease. They may come in and see me and say that I have borderline diabetes, or I have a touch of sugar, or, I don't have diabetes, but yet they're taking medications like metformin, or they're taking other oral medications, and they don't say they have the disease. But this disease is based on our ability to break down sugar. It's a complex chronic endocrine disorder. We get a deficiency of insulin. Our body should produce insulin to help us break down the sugar so that we can use it for energy and other things. But there's a defect in the pancreatic system. So there's deficiency in insulin secretion or insulin effect. And that leads to what we call hyperglycemia, elevated blood sugar levels. And those elevated blood sugar levels can lead to disturbances in our carbohydrate metabolism, how we break down fat and how we break down protein, and how our body, utilizes these nutrients that we take in our foods every day. And it can lead to a constellation of either acute or chronic complications. And I'll go over some of those complications as we talk about diabetes. I just really want to quickly go over the types of diabetes, because you may have a family member that has type 1 diabetes. Patients with type 1 diabetes need insulin. So if they have type 1, they're on insulin at a very young age. Patients with type 2 diabetes, which really results from the insulin resistance over time, which is majority of patients that have diabetes, up to 90% of patients who have diabetes have type 2. You see it as patients get older. We're seeing an increased incidence because of obesity and other health issues. These patients might initially start off with oral medications, and then as the disease progresses or due to poor control, these patients might be put on insulin. So just because a patient is on insulin doesn't mean they have type 1. Type 1 patients have to be on insulin. They're usually diagnosed at an earlier age. And again, it represents up to about 10% of all patients that have diabetes. Then if you know someone, a family member or friend who was pregnant and had gestational diabetes, the key takeaway for today is that those individuals are up to 60% more likely to develop type 2 diabetes 5 years after having their child. So it's important for these individuals to not only be seen while they're pregnant, but also to be seen for a yearly comprehensive dilated eye exam, and to have a follow-up care with their primary care physician, because they are at risk of developing this disease. And then certain medications like steroid medication, and this is important because with COVID-19, a lot of patients had respiratory illnesses that required steroid use. And so some patients can develop hyperglycemia or diabetes because of medication use. So some medications can predispose you to having hyperglycemia. Some patients might have genetic defects that might preclude them to having, or increase their risk for having diabetes as well. And sometimes in younger people, we're seeing an increased prevalence of diabetes. But a lot of these kids not only may be at risk because of obesity, because we're seeing a surge in obesity in our younger population, but also they may have this condition called latent autoimmune diabetes, which is an autoimmune dysfunction that leads to them having hyperglycemia. And then there is so many individuals, when we go over the numbers, that have pre-diabetes. In fact, 96 million people in the United States have pre-diabetes. Now, if someone says to me, I have a touch of sugar, or I have borderline, I usually am asking, do they have pre-diabetes? And your doctor will definitely counsel you on lifestyle modification, diet, and exercise to sort of prevent full-blown diabetes. So, but these individuals are at risk, and the numbers of patients having pre-diabetes is increasing. So this is a snapshot of diabetes currently in 2022. 37.3 million people have diabetes. That's 1 in 10 individuals. So we have some individuals on this call. 1 in 10 of us on this call, we have some type of diabetes. 1 in 10 individuals in the United States have diabetes. 133 million people have diabetes or at risk of having diabetes. That's half of the United States population. When we look at what is really important in this number is the people who don't know they have it. 1 in 5 don't even know that they have it. That's 8.5 million people who are walking around with diabetes, but they're undiagnosed. They're avoiding symptoms, they're avoiding going to the doctor, and they're at risk for complications, severe complications from this disease. And then 96 million people, that's 8 out of 10 adults, have some stage of prediabetes where their blood sugar levels elevated, but not elevated enough to be on medication. So they definitely have to do lifestyle changes. Why are those numbers important? Because diabetes causes a lot of complications. And one of the complications for me as an eye care practitioner is that it's the leading cause of blindness in working age adults. That's most of us on this call, those individuals that are 20 to 74 young. It causes weakening of the blood vessels in the eye, and these blood vessels bleed. And so the term is diabetic retinopathy. It causes fluid in the eye that can affect the macular area. And these patients are at risk for visual loss. The other thing that these patients are at risk for is kidney disease, chronic kidney disease. In fact, diabetes is the leading cause of end-stage renal disease, or the number one cause of patients to be on dialysis in the United States. But it's not just eye disease and kidney disease, but it's also, let me go back a little bit, I apologize, is foot and you know how you feel in diabetes nerve pain. In fact, diabetes is the leading cause of non-traumatic lower extremity amputation. A lot of patients come into my service and I know they have diabetes by their gait. They're shuffling because they can't feel the bottom of their feet. These patients develop sores that become gangrenous and they have to have a toe amputated. And these patients also can experience tingling and diabetes-related nerve pain. And other things that diabetes can cause is heart attacks and stroke. In fact, patients that have diabetes are 60% more likely to have early death from the disease. So what are some of the risk factors, right, for developing diabetes? Well, first of all, there's some things that you can do, and there's some things that you can't change. Non-modifiable risk factors are things that are hard for you to change. Your age, we're all growing up. And if you know someone or have a family member and you're growing up, you're over 40, 45, you need to be checked for diabetes. I would say even younger. Make sure that you're having a physical exam if you have a family history, know someone in your family that has diabetes. Race and ethnicity is really important. We are seeing a disproportionate number of patients that have diabetes are from the African American Black community, the Hispanic community, and the American Indian, Alaska Native communities, such as a higher prevalence of diabetes in those populations. Again, family history, genetics is important. Developing pre-diabetes. Patients, as I said earlier, with gestational diabetes are at risk. But there are some things that you can do, and I know this is titled the ABCs of diabetes, and we'll dive into what the ABCs of diabetes really mean. But patients that have high blood pressure, that's the B. If your pressure is not well controlled and you have diabetes in addition to high blood pressure, it can make your complications worse. It can make the disease worse. High cholesterol can also make the disease worse as well. Being overweight, obesity, and it's not just obesity, it's that central abdominal area. Patients that have a lot of central abdominal girth tend to have a higher risk of developing diabetes. I tell my students there's something called skinny fat. You can look normal, look healthy, but if you're not active, if you're not moving around, you can also be at risk for diabetes. And then, of course, smoking. Smoking is a big risk to exacerbate most conditions. And so one of the things that we want to counsel our patients on is discontinuing smoking to help them manage their diabetes. And this slide here really just underscores what I said earlier. When you look at the current prevalence of diabetes, the highest preponderance of this disease is in our minority communities, and the information is there. I do want to highlight a risk. In 2020, we had a pandemic. Of course, diabetes is an epidemic. It's not just increasing in the United States, it's also increasing worldwide. More than 500,000 people in the worldwide have some stage of diabetes, and that number is only getting higher and higher. But COVID-19 we saw a lot of patients not do well with the COVID-19 if they have diabetes. In fact, the risk for death from COVID-19 was, 4 times greater for those that had diabetes, and nearly 40% of patients who had COVID-19 and diabetes did not do well from this condition. And so COVID-19 hasn't gone away. It's still here. We're talking about RSV right now in children, but COVID-19 is still here. So I do counsel my patients on oxygen saturation. They can buy a pulse ox to make sure that they have good oxygen saturation. I do continue to counsel my patient on good glycemic control to make sure they don't have a reinfection of COVID-19, or a new infection of COVID-19 for these patients. And then we also saw a higher number because of the new onset diabetes related to COVID-19 and its treatment. Really quickly, ladies and gentlemen, I want to talk about some of the symptoms because sometimes you might have family members that express these symptoms. Did you know that going to the bathroom frequently could be a sign that you have diabetes? So if you have friends and family and they're running to the bathroom all the time, that could be a sign. I call it the 3 Ps. Polyuria is frequent urination. Also, too, you are eating, but you find yourself eating a lot more, polyphagia, because your body cannot break down the sugar. And, you have insulin deficiency. So you have sugar just floating around in your blood. That's why people call it sweet blood. But because it's not being broken down properly, you're not utilizing the foods that you're taking in, the carbohydrates not working properly, you're going to have increased hunger. Did you know that drinking a lot could be a sign that you have diabetes? Patients that are constantly drinking and constantly going to the bathroom and constantly eating, that's a sign that they may potentially have diabetes. For me as an eye care practitioner, one of the signs is blurred vision, fluctuating vision, change in vision. You go get glasses today, and then in a few months, those glasses don't work, and you have a family member that has diabetes, you might potentially be diabetic at that time. So you really definitely want to check your blood sugar, have a physical. Other things are weight loss and fatigue, tingling in the hands and feet, and slow healing. Could it be other signs? One of the key things when you have the disease, though, is duration really matters. The longer you have the disease, the more likely you're going to have complications. Having the disease greater than 10 years might lead to more complications such as diabetic retinopathy or other complications. But I also want to make sure that we understand duration is one thing, but also control of the disease. So let's talk about that. And this really just highlights again, duration is the single most important risk factor. So patient with type 1 after 10 years, up to 60% of them will have some stage of diabetes in the eye that's bleeding or some stage of complication. Greater than 20 years, almost 100% will have some stage of complication. For type 2, one of the key takeaways that I want you to see on this slide is that at the time of diagnosis, for me as an eye care practitioner, I see patients that come in with no history of diabetes, but yet they have bleeding in the back of their eyes. These patients are unaware. So a lot of times up to 33%, I diagnosed these patients. We saw over 500,000 patients a year ago that were diagnosed by just going to go get an eye exam because they had changes in the back of their eyes from bleeding. All right. So let's talk about the ABCs of diabetes. I always tell my patient, know your ABCs of diabetes. What are the things that you should know or you should talk to your friends about, family members about, is knowing their glycemic control, their hemoglobin A1C, and their blood sugar levels. The ones that do the finger stick, you need to know what their blood sugar level is on daily, not just to take their medication, but also to let that your doctor, your eye care practitioner, other members of the healthcare team know how well you are controlled. I always advise my patient to have a little notebook, documented some of the systems you can bring with you, and they'll have your readings over time, so you can bring up your reading. But the hemoglobin A1C is really one of the better tests. It monitors patients with type 2 diabetes, and it also can be diagnostic for patients with type 2 diabetes. So it's not as great for type 1 because these are younger patients, but definitely type 2. Their hemoglobin A1C level should be less than 7 is what's really recommended. In fact, the American Diabetes Association recommends 6.5 or lower. And this test is done every 3 months. So every 2 to 3 months, you go in for your diabetes diabetes related health checkup, they should do a blood test. And sometimes my patients don't know it's called the A1C, so I call it the 3-month blood test. But you should know your numbers. If your numbers aren't 7 or less, you have to do a little bit better in better control of your diabetes, because numbers that are greater than 7 increases the patient's risk for blindness from retinopathy and kidney disease, stroke, diabetes-related nerve pain, and heart disease. And as I said earlier, know your blood pressure. What should the blood pressure be? The new blood pressure guideline says that, well-controlled blood pressure should be less than 130 for your top number, which is your systolic, and less than or equal to 80 for your blood pressure. Anything greater than that can be diagnostic for high blood pressure now. So really best control is to have your blood pressure lower than these numbers. And also if you have blood pressure and diabetes, those two can make your disease worse. They exacerbate each other. Cholesterol levels. There are a lot of patients who have diabetes that also have cholesterol, high cholesterol. And it's important to know your cholesterol level. I always tell my patients with diabetes, know your good and your bad cholesterol. The bad one is really the one that you really want to lower, so that's your LDL. So I always tell my patients, know your bad guy, because if you can get that lower, you'll do so much better. So a lot of my patients are taking medication for cholesterol if they have diabetes as well. And then also too, I counsel patients to stop smoking. Smoking increases, exacerbate all condition because it leads to hypoxia, ischemia. It makes the blood vessels not work properly. And so you add that along with diabetes, you can increase your risk for having complications. And this is just a pictorial just for the audience to kind of understand. When we say sweet sugar, your blood is sweet, or sweet blood, excuse me, that means that the sugar, the blue here, is bound to the red blood cells. And it's just floating around in the blood. It's just going, it's not being utilized. So the A1C detects the amount of sugar that is bound to your red blood cell. And again, that number should be 7 or less. But not all of us are doing so well. About half of the patients that have diabetes based on this new data have an A1C above 7. I've seen patients with A1C of 10, 11. The higher the A1C, the more your risk of complications. And, studies after studies have shown just even a 1% decrease in your A1C. If you go from 8 to 7, you're decreasing your risk of developing complication. For me as an eye care practitioner, when it comes to retinopathy, that's up to 21%. I would rather my patient preserve their sight. So these are small increases. If you can go from 9 to 8, I want 7 and get to 7, it can decrease your risk for developing not just retinopathy, which is the bleeding in the back of the eyes, but also kidney disease, nephropathy, as well as neuropathy with diabetes-related nerve pain, the bottom of your feet, the amputation risk. And then, of course, not just the small blood vessels, which are those micro blood vessels, but also the bigger blood vessels. So you're decreasing your risk for heart attack and stroke. I use this picture of the retina. And so just to describe the retina, this is a patient of mine who has diabetes, but also to you see his blood pressure. He was well controlled. He was doing really well. You can see he has some changes. These are hemorrhages or bleeds in patients that have diabetes. He has some bleeds here, some small bleeds. He was doing really, really well. But then he lost his wife and he got really depressed and he stopped taking all his medication. And a year later, from 2013 to 2014, you could see that he has more bleeds in the back of the eye. But look at his blood pressure. It's really very elevated. So in addition to having high blood pressure and his diabetes, it made his condition worse. So I use this image to show you how the retina would look and how having high blood pressure, it not being well controlled, can make your conditions worse. So just treating your blood pressure, making sure your blood pressure is well controlled, can decrease your risk of death by 32%, eye disease such as retinopathy, by 37%, stroke and heart failure by even 56%. So controlling your blood pressure is really important. Following your doctor's recommendation. Cholesterol, again, a lot of our patients that have diabetes have high cholesterol. We want to make sure our patients have low LDL as opposed to high LDL. And we want them to have LDL, which is your bad lipoprotein. And then we want the patients to have good or high, good lipoproteins and lower triglyceride levels. So a lot of these patients are taking medication for their cholesterol, but it's important for me to ask about that. All right, so I'm going to ask the audience in the chat, and I'm going to have Angela and Angie assist me. But what eye condition is the leading cause of vision loss? I said it earlier, for patients that have diabetes in the United States. Let's see here. I see a lot of questions in the chat box. And diabetic retinopathy, I see as an answer. That's correct. Diabetic retinopathy is the leading cause of blindness in working age adults, and all of us are very young. And this is how diabetic retinopathy looks. Earlier picture that I showed you, again, you just see a lot of bleeding. These yellow spots could be leakage or ischemia signs. But this is a patient who has an A1C of 8, 9, not well controlled, or has diabetes for a very, very long time. All right, and then for patients, sometimes these blood vessels, because they are fragile, your body says that I have to develop new blood vessels. So they develop these new blood vessels in the retina, and these blood vessels can leak and burst in the eye. So patients with diabetes may have a sudden loss of vision because that blood vessel bursts. But this slide, what I really wanted to take home is that a lot of patients that have diabetes have some stage of retinopathy, and that good vision doesn't tell me what's going on. It's important that patients have a comprehensive dilated eye exam, even if they say they have good vision. These are the stages, again, of diabetes related retinal disease or diabetic retinopathy. You can have early, you can have severe. These are just illustrations of the new blood vessel that's grown over the nerve, these sort of fine lacy vessels. Those vessels leak, and then of course you can get a lot of leakage in the back of the eyes. These patients that have new blood vessels or a lot of leakage, if you have friends or family members that have that, they're getting treatment. And one of the treatment could be injections in the eye. And there's always a fear for patients that have diabetes about injections in the eye. So a lot of times you gotta I have to talk to my patients about that. There's no pain. It's really a quick, simple procedure. In the past, they used to do laser treatment. So you would go, you would sit, they would numb your eye, and they would do these little laser lights in the back of the eye. But the newest treatment for the last 10 years or so has been injections in the eye, medication that helps to decrease these new blood vessels and decrease the swelling so that we can preserve your sight. But it's not just the bleeding that I'm worried about in patients that have diabetes. If their A1C, their blood pressure, their cholesterol, or they're smoking, patients are at risk for cataracts. So you can develop cataracts, and that's another potential sight robbing condition, right? You can develop it sooner, earlier, because you have diabetes. Also, patients with diabetes can develop a condition called glaucoma. We talked about glaucoma the last time I was on, and glaucoma is a silent thief of vision. There are no symptoms with glaucoma. It slowly affects the nerve in the back of the eye and causes the nerve to be damaged. And eventually, as the disease progresses, and when it gets to the end stage, patients are blind. It's irreversible blindness. But patients with diabetes are 40% more likely to develop glaucoma. So every time a patient with diabetes should have an eye exam, you should be asking, do I have glaucoma? Did you check for glaucoma? And again, it can cause other forms of bleeding in the back of the eye. A lot of times these bleeding changes, there's no symptoms. That's why it's important to have a dilated yearly comprehensive eye exam. I wanted to just go over this quick chart because this is really important for me. Every 24 hours in the United States, you know that approximately 4,500, that's 4,557 adults are diagnosed with diabetes. And I suspect that number is probably higher. That's every day. in the United States. 136 people begin treatment for kidney disease, dialysis, and again, I suspect those numbers are higher. Every day, 200 non-traumatic lower limb amputation are performed, and 641 people die from diabetes. And then for me, 55 people every hour become blind from this disease. So we talked about the ABCs of diabetes. I wanted to end a little early so I can answer all the questions that are in the chat box. But what can you do if you have diabetes? What can your family members do if they have diabetes? Your friends, your associate? Important things. Take your medication. Follow what your doctors are saying to you. I always think it's important to, I had a conversation with a patient. She didn't know she had diabetes. She was on metformin, wasn't sure why she was on metformin. When you have a primary care physician, you should be able to talk to your primary care physician. So I'm a patient advocate. And so if your doctor doesn't have a minute to talk to you, find a new doctor. There are side effects to medication. A lot of times patients might have a complication from metformin. Don't stop the medication. Talk to your doctor about the medication. The next thing I want you to do is reach and maintain healthy weight. You know, studies after studies have shown that just 30 minutes of cardiovascular exercise 3 times a day can reduce your risk of developing diabetes. So for my patients that have pre-diabetes, you don't have to develop full-blown disease as long as you're doing what is appropriate with lifestyle management and exercising. So yes, exercise, but it's cardiovascular exercise. And now we all have Apple Watch, you know, that's 20,000 steps a week is equal to about that amount of exercise. So make sure that you're maintaining a healthy weight. You're eating healthy foods. You know, there are vitamins, eye-friendly vitamins that have been shown to help patients with diabetes to sort of eye protective, lutein and zeaxanthin that are similar to what patients are taking for macular degeneration, has been shown to be beneficial for patients that have diabetes. Newer studies have looked at patients that have low vitamin D levels. If your vitamin D levels, if you're not going out and getting sunlight, your vitamin D levels could be low, and that can increase your risk of developing diabetes. So if you were told that you have low vitamin D and you're taking vitamin D, it will help you with your diabetes. Add more physical exercise, as we said earlier, and control your ABCs of diabetes. If there was any reason to stop smoking, this will be a reason to stop smoking. Make sure that you're taking your medication for blood pressure. Make sure that you're minimizing salt in your diet and that you're eating healthy. Make sure that you're taking your cholesterol medication. I know that some studies have shown that some cholesterol medication can cause your sugar to go up. So really talk to your doctor. And then, of course, kick the smoking habit. Smoking is really bad. It's bad, bad, bad. And so, you know, I want to advocate for patients to stop smoking because it can make their disease worse. And then it's so important to have a dilated eye exam every year. If you have diabetes or you have pre-diabetes, you had gestational diabetes, you know, just having a yearly comprehensive dilated eye exam is really important. Again, up to 33% of patients with type 2, it is found during a dilated eye exam. And this is what I was saying about brisk walking, cycling. Those are good cardiovascular exercise, and it reduces your risk of developing diabetes by 40%. A big study that looked at taking metformin and exercise, the exercise group was just as efficacious in controlling their diabetes, reversing their diabetes, you know, especially the pre-diabetes as compared to the metformin group. So exercise really, really is important. And then I just want to leave by just mentioning, or end by just mentioning, diabetes is a multidisciplinary disease. It's a multidisciplinary approach. You know, everyone that has diabetes has a diabetes team around them. And what's important for me as an eye care practitioner, it's important for me to communicate my eye findings to your primary care physician. It's important for your primary care physician to recommend you get a dilated eye exam every year. It's important that if you're going to a retinal specialist, if I have to refer you to a retinal specialist that's going to inject the eye, that your primary care physician, your endocrinologist, the nurse practitioner, they're part of the team. If you've seen a podiatrist, they're part of the team. If you've seen a dentist, you know, diabetes can cause periodontal disease and other diabetes related gum disease or tooth decay. And so patients, you know, just making sure that they have those diseases, that they are also getting an eye exam. We know that diabetes can cause cognitive decline and depression and mental health is really big right now, especially COVID and what's going on. So if I have patients that are depressed, not only am I communicating with their diabetes healthcare team, but also making sure that they get the behavioral, you know, resources that are needed. So in conclusion, if we live well, we age well, and we see well. And that is true for patients with diabetes as well. Again, I'm part of the NEI, NEHAP, and these are some of our resources. I do want to let you know that this is, again, National Diabetes Awareness Month, and there's some resources I'm more than happy to share with anyone that requests. We also have resources on other eye conditions, including glaucoma and cataracts, that are available and that we can offer to you as well. Outreach material library. So if you have a church and you want to do community health fairs, we have some resources that can help you get information out about diabetes and other eye condition. And then another resource that we have is to help our patients, because we understand one of the barriers is financial. And so there are some resources that can help us provide eye exam for our patients that have diabetes. And of course, the National Eye Health Education Program, which is I'm so proud to be part of, also has resources. All right, so I am ready for questions, Angela and Angie, from the audience. So let's see what's in the chat box.
Thank you so much for such an awesome presentation. We have a lot of questions in the chat, so I'm going to read them to you and so we can get started. The first question is diabetes hereditary? Many of my paternal relatives have type 2 diabetes. Will I?
So diabetes is a genetic disease, unfortunately. So if you have a family member, an uncle, an aunt, your mom, your dad, your paternal grandmother, maternal grandmother, you should be checked for diabetes. And let me just also let you know, a lot of times patients say, well, I don't have no one in my family that have diabetes. It may not be your direct grandparent or mother or father, but it is in your bloodline. So if you have uncles and aunts that have the disease and your parents may not, then you're at risk for diabetes. Also to age, as you get older, you're more at risk. Your body doesn't work as well. So again, if you have a family member who has diabetes, and as you get older, you may not have the disease at their age, 45, but it's not unlikely to see it as you grow up and you see it at 50, right? So yes, if you have a family member that has the disease, you're more than likely to develop the disease. Is there anything that you can do to not have diabetes if you're a family member? Again, you can delay the onset with lifestyle changes, healthy eating, diet and exercise, but you still may potentially develop the disease. It just delays the onset.
Thank you. And I'm going to sneak a question in here. As we approach the holidays and we look forward to gathering with our family and eating delicious meals and desserts and so forth, is there any guidance that you can give us to maintaining or starting that lifestyle eating healthy regimen, or should we wait until the new year to think about that?
You know, there's always this New Year's resolution, and then halfway through the New Year's resolution, we forget it. Patients with diabetes, friends and family that have patients with diabetes, or I think it's, and also too, when the management of diabetes is a family affair. So I say if you, the holidays, I don't want my patients with diabetes not to partake, but limit yourself. Watch what you're really eating. Can you have that sweet potato pie? Maybe you can have the sweet potato pie. There are food items that hopefully will be on the table that are healthier options as opposed to a lot of carbs, a lot of sweet foods. Avoid those. And if you do partake, I would say my aunt had diabetes, and when she would come over, I would say maybe a small piece of cake, Auntie. You can't have a slice of cake, but make sure you're taking your medication. Maybe the next day we're walking in the morning to better kind of ward off some of the changes that we did the night before. But definitely don't wait till the new year. It should be an everyday occurrence. Even on Thanksgiving Day, if you got up and you walk a little bit and you went over to your family's house, that's still what you should be doing the next day after and the next day after. You want to do that.
Thank you. Our next question asks, can you please speak to diabetes retinopathy a little bit more? Can you define that, please?
Yeah, so basically, when you have diabetes, it impacts both the small and the large blood vessels. And the blood vessels in the eye are your small blood vessel, your microvascular blood vessels. And the blood vessel in your body are your large blood vessels. So when I say macrovascular, that's more the large one. What happens with diabetes, pathophysiology, it makes the blood vessels in the eyes weak. The hyperglycemia, the elevated blood sugar, it can affect the function of the blood vessels in the back of the eyes. Those blood vessels become weak. When they become weak, they can leak blood and bleed blood, but they also can lead to lack of oxygen to the eye, because one of the things that your red blood cells do is help to deliver oxygen to the target organs in your body, right? And so if your blood vessels aren't working properly, the red blood cells aren't working properly, you can't get oxygen. So there's two things: you get weakening, you get lack of oxygen, or hypoxia is that term, and then you can get bleeding, you can get release of some of these, I call them inflammatory markers, and they cause swelling and other changes in the eyes. And that's what leads to the retinopathy. The retinopathy can be early. And when it's early, your eye doctor should follow you very closely, and you don't need treatment. You can be monitored closely. When the retinopathy becomes moderate, we're seeing a lot of bleedings in a bleeding spot in the retina, a lot of leakage, a lot of different changes. We will refer you, most eye doctors will refer you to a specialist, and that specialist is called a retinal specialist. And that retinal specialist will do some testing to look at the eyes to see how bad the changes are. If there are new blood vessels, because there's lack of oxygen, so the body says, I got to get oxygen, so it develops new blood vessels in the retina. So neovascularization is the fancy term. And when you have new blood vessels that form, or neovascularization, or a lot of fluid, they're going to inject the eye with a treatment. So it's an anti-new blood vessel growth medication. So those new blood vessels regress. What happens with those new blood vessels, they can bleed. And if you think about a snow globe, is how I describe it to my patient. There's all this snow in there. And imagine you fill it up with red blood. Imagine trying to see through red blood. You can't. That's how the eye is. It's like a globe. And so if you get bleeding into the vitreous, which is the jelly part of the eye, you can't see. And some patients develop vitreous hemorrhage, and it's a little bit more severe, and some patients might develop retinal detachment because of that.
Thank you, Dr. Reynolds. The next is type 2 diabetes more prevalent in men or women of color? And if so,
Thank you for that. I didn't put that statistic up from the National Diabetes Statistic Report 2022. When you look at African-American men and women, it was a little slightly higher in women, but it's about the same. And, you might say, well, women are slightly higher because, a lot of times there's single family home, there's a lot of stress, and again, diabetes, the social determinants of health, urban deserts, access, financial barriers, can always cause those numbers to be a little, but definitely between Black men and Black women, it's roughly about the same or a little higher for women.
Thank you. And our next question reads, can your A1C be normal and can you still have diabetes?
So the question is, so A1C can be used to diagnose your condition. And so if your A1C is borderline high, 5.4 to 6.5, you may be told you have prediabetes. And so if it's not high enough or it's in a normal range, even if you have a family member, then your doctors will counsel you and see you back every year. And I always tell patients, like cholesterol, when I was young, my cholesterol was normal. But as we age, your cholesterol level changes the way your body works. So it could be normal 1 year, but it could change from 1 year to the next. So yes, if your A1C is normal, you don't have diabetes. If your A1C is borderline high, you should be told that you have prediabetes and to incorporate lifestyle changes, exercise, and diet. And if your A1C is, I think about 6.5 is what the number is, or high, you have diabetes and the patient will be treated.
Okay, thank you. And the next question reads, can my local pharmacist help me measure my blood pressure and my cholesterol?
Most pharmacy have a clinic that is adjacent to it. I know at Nova Southeastern, our pharmacy has a little mini clinic. So for our patients that have diabetes, they do check A1C and they do check blood pressure and they check cholesterol. You can definitely check your blood pressure at most pharmacies, and most pharmacies can, if they have a program or clinic that's adjacent to it, can check your blood sugar levels and your A1C.
Thank you.
And there is also too an at-home A1C monitoring. It's called A1C Now. Some doctors recommend that for patients who are not well controlled, but maybe have a transportation issue, cannot get back to the office, it's in a rural setting. They may offer an at-home testing device for patients to test it at home.
And Dr. Reynolds, does insurance, private insurance, Medicare, Medicaid pay for these at-home tests?
I'm not sure about that. I would have to look that up, but I'm pretty sure they should, but I can't give you a confirmatory answer. I would say to my patients that have that need that they speak to their doctors about that. So there are some that would be covered and some that may not be covered for that.
And to that extent, you've encouraged us to get a comprehensive eye exam, especially for those who are living with diabetes. Does insurance pay for that comprehensive eye exam? And if so, how do we know if it's comprehensive?
So most insurance companies do pay for. In fact, there is it's called the HEDIS report. But what that really means is the insurance company wants to know that you're having a well check, right, to ward off disease. And they want to know that you're having your yearly diabetes eye exam. So a lot of insurance companies require for us as eye care practitioners to submit a report that the patient had their eye exam. But yes, your insurance should cover a yearly comprehensive eye exam. What do I mean by yearly comprehensive dilated eye exam? I want all my patients that have diabetes, everyone on this call, to understand when you go in and get an eye exam, if they just check you for glasses and they don't take a look at your retina, then that's not a comprehensive dilated eye exam. And you do have some places where they just check you for glasses. I've had patients who've come to me and said, I went somewhere and got new glasses, but they didn't dilate my eyes. They didn't look at the back of my eyes. Most eye doctors should be looking at the back of the eyes. They do have imaging devices now that allows us to capture a wide field image of the retina. And we have that image at our clinic, but I still am an advocate for a dilated eye exam. The imaging device can detect bleeds and retinal changes. And so I like to use the images to show my patients. A lot of time, if they see it, they believe it. So it's one thing to tell a patient they have retinopathy, but if they see the bleeds in the back of their eyes, they're more likely to follow through with follow-up care and understand the disease better. Also, too, the American Diabetes Association recommend telescreening. We know that, again, some of the barriers to care could be access, transportation issues. And so you have some doctors now that are capturing images of the back of the eye. And if they see changes, they refer the patient for that next level care for the patient. So yes, there are some doctors that are doing imaging of the eye by taking an image of the retina, a photo of the retina, but I still advocate for a comprehensive dilated eye exam. And that dilated eye exam is putting drops in the eyes. It opens up the pupils, so it allows me to see the retina better. And then I use a device, a little lens, so I could see better into the retina. And then I have you look up, down, left, and right. I use another device to look at the peripheral part of the retina. So that's a dilated eye exam.
Okay. And I'd like to add to that, is there any downtime with getting a comprehensive dilated eye exam?
I recommend a patient that has diabetes to have a comprehensive dilated eye exam every year. If you have retinopathy, you will be dilated more frequently every 3 to 6 months. I really advocate yearly that you have these eye exams because you can develop retinopathy at any stage, any time of the disease. And remember, the longer you have the disease, the more likely you are to have some stage of retinopathy, the less control you have, or if it's not well controlled or is poorly controlled. So ladies and gentlemen, if you have an A1C of 8, you should have had an eye exam. If you have an A1C above 7, you should have an eye exam. Everyone should have an eye exam every year, but the higher the numbers, the more the risk of complications are. So I recommend a yearly exam. I don't want my patients with diabetes to wait. We do have a lot of patients because of the COVID-19 pandemic who did not come in for 2020 and 2021 because of the social distancing and their disease and not wanting to put themselves at risk. But now with 2022, and I know the virus is still out there, and my patients with diabetes should be cautious. Our patients with diabetes should be cautious with the COVID-19 virus, but they should definitely get a yearly comprehensive eye exam.
Thank you, Dr. Reynolds. And if our healthcare providers, our eye care providers, our wellness physicians, our dentists, how do we get them all on one accord? If they don't talk to one another, what can we do to advocate for ourselves to make sure we have them all on one accord and they each know what is going on with our eyes and so forth?
I want to advocate and inform all the patients that are on this call today, or if you have family members that have diabetes, friends, associate, ask them, did your doctor send a report to your primary care physician? Ask for an exam report. After your eye exam, make sure that that doctor sends a report to your treating physician. Make sure your treating physician know that you went and got an eye exam. They should be documenting that as well in their histories and in their charting. So communication is key. If you're seeing a nutritionist, I think it's important to let the nutritionist know that you have retinopathy because that is a complication that you have from the disease. If you're seeing a podiatrist, patients, I always say that patients that have nephropathy, kidney, they have foot disease or they're seeing a podiatrist, they're at a higher risk of having retinopathy or bleeding in the back of the eye. So, those patients should be asking, at Nova Southeastern is an interdisciplinary approach. We have a dental clinic, an eye clinic, a health clinic, and we communicate. But if you have periodontal disease or you know someone or you have loved ones that have periodontal disease and they have diabetes, they should be having a yearly eye exam. I think that's really important as well. So I think I'm going to advocate for the patient to be the best advocate because they're seeing the individual doctors. So make sure that your doctors are communicating, make sure that they send an exam report and make sure that, there's reports about whether you have retinopathy or not, or you're being treated by the retinal specialist. Because the other thing is, if a patient with prediabetes comes to see me and they have retinopathy, that means they don't have prediabetes. They have diabetes and they should be treated. And the primary care physician, the endocrinologist needs to know that. So that's why the reports are so important.
Thank you, Dr. Reynolds. And we have a question here in the chat, and it reads, does smoking include all forms of tobacco, including marijuana that's used for pain management?
This is an interesting question. So I am not an expert on medical marijuana. I would say speak to your physician about that. When I say smoking, it's really the nicotine. If I were to say the nicotine is the bad guy. And so patients that not only smoke, regular cigarette, but electronic cigarette, e-cigarettes that have the nicotine, tobacco smoking as well. I'm not sure of any studies yet, or maybe there have been some studies that I'm unaware of that looked at marijuana smoking and diabetes. But I would advocate that you talk to your primary care physician about that, and they can give you a better answer.
Okay, thank you for that. Our next question reads, will ARDS2 vitamins mitigate the effects of type 2 diabetes?
Yes, and I mentioned that earlier. So AREDS was the age-related eye disease study, and it was a major multi-center study that looked at macular degeneration. And so the vitamin combination includes, vitamin A, E, and lutein and zeaxanthin. Lutein and zeaxanthin has been shown to be very efficacious. It helps to decrease oxidative damage and stress on the cells in the eye. So we do have patients, and I do have patients that I recommend eye-friendly vitamin. There's a vitamin called the Diabetes Vision Formula, so the DVS formulation vitamin. And again, it has lutein and zeaxanthin and other nutritional support that help patients with diabetes. So yes, the AREDS formulation has been used to help with eye health, overall eye health.
Thank you. Thank you, Dr. Reynolds. We have a question and a comment in the chat, and it reads, some retinal specialists don't like it when patients advocate for themselves. What should I do?
So continue to be your best advocate. So if your retinal specialist is injecting in your eyes, and one of the things that we find is a lot of times patients don't understand the purpose of the injections is to decrease, to prevent complications, right? So you have these new blood vessels, they can bleed. So the goal of the injection is to regress or stop the growth of those. We also do the injection to stop fluid from accumulating in either the macula, diabetic macular edema, or fluid in other parts of the retina. And so the injections are important, but it's not one injection. It may not be 2 injections. It may be monthly injection. It may be several injections. So where we're finding patients that who have diabetic retinopathy, it's something called injection fatigue or injection not understanding. And so if you're having injections, you're having a series of injections, you're not sure if it's working, you're not sure if this injection is making your vision better, please speak to your eye care practitioner. If it's not the retinal specialist, the optometrist. When patients come to me, they're like, Dr. Reynolds, I don't want to get any more injections. I'm tired of these injections. And I have to take a moment to educate again. We're all part of the team, and educate the patient that these injections are important and that they're helping to decrease the swelling and preserve their sight. And also we're all part of this healthcare team. And so they're developing new injections that won't be every month or every 2 months, but maybe every 4 months. So your retinal specialist will have more in their arsenal to treat patients. And we've come a long way with research and advances in treating the patients, and even earlier detection of diabetic retinopathy or diabetes-related retinal disease. And the other thing I wanted to make sure I mention, patients with diabetes is the key word. We don't use diabetic patient. We don't want to describe patients because of their disease. It's a patient that has diabetes so they can take control of their diabetes. It doesn't define them as having diabetes. So when we talk to our patients that have diabetes, make sure we say the patient with diabetes as opposed to the diabetic patient.
And looks like we have one question in the chat, and actually time for one more question, Dr. Reynolds. And the question asks, can you please speak to controlling my lifestyle? I fail miserably at lifestyle control.
Lifestyle control is a very challenging thing. And I think that I advocate for my patients to speak to their physician, their treating physician, to maybe refer them to a nutritionist, number one, and a dietitian, number two, because they can give you more guidance as to some ways or some steps or some new technique to incorporate to really help with lifestyle. A lot of times that means exercising, but I know it's hard for a lot of patients to plan around that, but a dietitian and a nutritionist can help you better with food preparation. What are the better foods for you to have, to cook, what type of diet should you be following? A dietitian can help you with exercise, or maybe refer you to exercise specialists to help you with different types of exercise techniques. I said cardiovascular. For me, I always advocate for my patients to walk. And even for those that have diabetes, nerve pain, or have advanced disease, or have mobility issue, even if they walk in place, it's doing better than sitting down all the time. So I would advocate that you speak to your primary care physician about speaking to a dietitian and a nutritionist when it comes to lifestyle and foods and nutrition.
Perfect, a perfect segue. We are exactly at 2:00. Dr. Reynolds, thank you very much for joining us again. We hope you will join us in the new year. And to our audience, thank you for your awesome questions. If we didn't get to your question this afternoon, we will share your question with Dr. Reynolds, and she has so graciously said that she will answer your question, and we'll get back to you with her answer. Again, thank you, Dr. Reynolds, for joining us, and to our audience, thank you. We give you back your afternoon and wish you a happy Thanksgiving.
And I want to thank the National Caucus and Center on Black Aging for having me. Thank you so much.
Thank you. Good afternoon.